All right, let's jump right in today. We're revisiting Morgan and Mikhail, going back to the basics with chapters 7 and 8.
Yeah, always good for a refresher. Pharmacokinetics, pharmacodynamics, the cornerstones of, well, pretty much everything we do.
It's kind of amazing how those concepts, they really do guide every decision we make in practice.
Totally. It's that foundational knowledge that helps us connect the dots between what we read and what we do in the OR, and honestly helps us keep our patients safe.
So true. So first up, pharmacokinetics, what the body does to a drug.
Yeah. ADME, absorption, distribution, metabolism, excretion. It's like that roadmap we use to understand a drug's journey through the body.
Exactly. And I think remembering ADME makes it so much easier to, like, actually visualize what's happening.
Oh, absolutely. Visualizing it can be super helpful. And it's key when we're tailoring anesthesia for, our individual patients, making sure it's both safe and effective. I mean, take absorption, for example.
Yeah.
A drug can't work its magic until it gets into the bloodstream, right? So absorption is that first hurdle it has to overcome.
It's almost like those escape rooms. Like, it has to navigate all these obstacles to reach the goal.
Uh-huh. Perfect analogy.
And like with those escape rooms, lipid solubility is key, right?
For sure. A drug that can dissolve in fat can basically slip right through those cell membranes.
That makes sense. So it needs to be lipophilic to have good absorption.
Exactly. Now think about aspirin.
Okay, yeah, good old
It's
aspirin.
acidic, so it gets absorbed best in the acidic environment of the stomach.
Right, makes sense.
But then you have something like codeine.
Oh, interesting. So how is codeine different?
It's basic, so it actually prefers the more alkaline environment of the intestines for absorption.
Ah, okay. So the environment plays a huge role in how well a drug is absorbed.
It definitely does. We can really see how that plays out in practice, right?
Totally. And that absorption is just the first step. Then comes distribution, where the drug gets around the body.
Right, it hits the highway, basically, hopping onto the bloodstream express.
Exactly. And I've always found it fascinating how some drugs, like propofol, they reach the brain so quickly.
Yeah, propofol is a speed demon. It's all thanks to high cerebral blood flow.
Oh, okay. So blood flow is key here. More blood flow means faster delivery to the organ.
Exactly. But, it's not as simple as just hopping on the bloodstream and going wherever.
Right. It's not a free-for-all in there.
Not at all. Some drugs, they like to hitch a ride on proteins in the blood.
Protein binding.
Right.
Yeah.
Exactly. And only the free drug, the unbound stuff, can actually interact with those receptors and do its thing.
It's like those protein-bound molecules are taking a little break from the action.
Uh-huh. Yeah, exactly. Taking a back seat. And this all ties into redistribution, too, where drugs move from those highly perfused organs like the brain to other tissues.
So that's why sometimes a patient might wake up from a short procedure, even if the drug hasn't fully been eliminated. It's redistributed to other tissues.
Right on. It's moved out of the brain, so its concentration drops and the effects wear off.
So that redistribution affects the drugs, what was it called?
Context-sensitive halftime.
Yes, context-sensitive halftime. That's how we can predict recovery times better than just looking at the elimination half-life.
Absolutely. It's like with fentanyl, for instance. The longer the infusion, the more that context-sensitive halftime matters for predicting how long it'll take to clear the body.
So redistribution and context-sensitive halftime, those are really important things to consider, especially for our longer procedures.
Especially when we're planning extubation and recovery, yeah.
Okay, so absorption, distribution.
Mhm.
Now it's time for the liver to do its thing, right? Metabolism.
Right. The
And-
liver's the processing plant, breaking down those drug molecules.
Propofol, for example, is metabolized really efficiently by the liver.
Right. Super efficiently. So, if a patient has liver issues, that'll definitely affect how long propofol hangs around.
That makes sense. And there are two phases to how the liver handles metabolism, right?
Yeah. Phase I is it's like adding those functional groups to the drug molecule, making it easier for phase 2 to do its thing.
And what's phase 2?
Phase 2 basically tags the drug with a molecule to make it water-soluble so it can be easily excreted.
Like adding a shipping label for excretion.
Perfect analogy. And speaking of excretion, that's mainly handled by the kidneys.
Right. Filtering the blood and getting rid of those water-soluble metabolites through the urine.
Exactly. And, it's interesting because urine pH can actually influence how well a drug is excreted. Like if someone overdoses on phenobarbital.
Oh, right. Phenobarbital is acidic, so...
And we can alkalinize the urine to help get rid of it faster.
So manipulating the urine pH can be a really powerful tool in managing overdoses.
No doubt. It's a trick of the trade, you could say.
And there's also that other process that can come into play, enterohepatic recirculation,
Oh yeah, that one can be tricky. It's where some drugs get excreted in the bile, but then get reabsorbed back into the bloodstream from the intestines.
like a surprise encore.
Exactly. And lorazepam is a classic example of a drug that goes through this. That recirculation can really prolong its effects, something we need to be mindful of when we're managing sedation.
Absolutely. So, okay, we've covered absorption, distribution, metabolism, and excretion. The whole journey a drug takes through the body.
The entire adventure. And understanding each step helps us make the right choices when it comes to choosing drugs, dosing them, and monitoring our patients.
It's like having a behind-the-scenes pass to the whole production.
Uh-huh, exactly. And once you understand the pharmacokinetic side of things, it sets the stage for pharmacodynamics, how those drugs interact with the body to actually produce their effects.
Which is a whole other fascinating story for us to unravel.
Totally. And we'll dive into that right after this break. So, pharmacodynamics. This is where the real action is, how drugs interact with the body to, actually do their thing.
It's like the drug finally gets to the party after that whole pharmacokinetic journey.
Exactly. And it's all about how those drugs interact with their targets, like how that molecular key fits into its specific lock.
And that interaction triggers a whole cascade of events.
Yeah.
Leading to the effects we see in our patients.
Right on. And, when we're talking about this interaction, we often throw around terms like potency and efficacy.
Ah, yes. Potency and efficacy. Those two always seem to trip me up in school.
Yeah, they can be a little tricky, but understanding the difference is super important when we're choosing the right drug and making sure it's working as well as it can.
Okay, so can you break it down for us? What's the difference between potency and efficacy?
Sure. Imagine we have two drugs, drug A and drug B, both designed to relieve pain. Drug A gives us pain relief at a dose of 10 milligrams.
Okay, 10 milligrams of drug A for pain relief. Got it.
Now, drug B does the same thing, relieves the pain, but at a dose of 5 milligrams.
So we need less of drug B to get the same effect. So that means drug B is more potent, right?
You got it. Potency is all about the dose, how much drug we need to achieve a certain effect.
Okay, that makes sense. So potency is the dose. What about efficacy then?
Okay, so let's say both drug A and drug B can relieve pain. But drug A at a certain dose can completely eliminate the pain, while drug B, no matter how much we give, only reduces the pain to a certain level.
Oh, I see. So drug A has a higher efficacy because it can achieve a greater effect.
Exactly. It's like the ceiling of how well a drug can work.
So a drug can be super potent, meaning we need a tiny dose, but it might not be very effective in completely getting rid of the problem.
Exactly. It's like, comparing a scalpel to a hammer. Both are tools, but they have different strengths and limitations.
Okay, that makes sense. Now, how does this play out with the drugs we use in anesthesia?
Well, think about fentanyl. It's incredibly potent. We only need a tiny amount to relieve pain.
Yeah, fentanyl is strong stuff.
But its efficacy for pain relief is basically the same as morphine. It can't take away pain any better than morphine can.
So it's not like fentanyl is magically better at relieving pain. It just works at a much lower dose.
Right. So both potency and efficacy are important things to consider when we're choosing which drug to use.
Absolutely. We want to make sure we're choosing the right tool for the job. And speaking of finding that sweet spot, there's also the concept of the therapeutic window, right?
Ah, yes, the therapeutic window, that Goldilocks zone where the drug is working its magic without causing too many side effects. It's all about finding that balance.
Like walking a tightrope. We want enough drug to do what we need, but not so much that things start going sideways.
Exactly. And those therapeutic windows, they can vary quite a bit between drugs. Some have a wide window, giving us more wiggle room with the dose, others not so much.
Those narrow therapeutic window drugs definitely keep us on our toes, especially in anesthesia where precision is key.
Absolutely. Speaking of precision, let's shift gears to inhaled anesthetics. Those are fascinating because they get to the brain so fast, perfect for inducing anesthesia.
Yeah, they really do work quickly. But how do they do that? What's the mechanism behind their rapid action?
It all boils down to partial pressure. That's the pressure a gas exerts within a mixture of gases. So with inhaled anesthetics, the partial pressure in the alveoli is what determines how much gets into the blood and ultimately the brain.
So the higher the partial pressure of the anesthetic in the lungs, the faster it gets into the bloodstream.
You got it. It's like a concentration gradient driving the anesthetic from the lungs into the blood.
That makes sense. And we measure that partial pressure in the alveoli using alveolar concentration.
Exactly. Alveolar concentration tells us how much anesthetic is in the alveoli as a percentage of the total gas mixture.
So it's not just about how much anesthetic we're giving, it's also about how much is actually getting to the lungs.
Right. And it's also important to remember that blood solubility plays a role, too.
Oh, right. Blood solubility. That affects how easily the anesthetic dissolves in the blood.
Exactly. A highly soluble anesthetic, it dissolves in the blood like sugar in water. It takes a while to saturate.
So it takes longer for the anesthetic to reach the brain.
Exactly. It gets kind of stuck in the blood. But a less soluble anesthetic, it doesn't hang out in the blood as much, so it reaches the brain faster.
So a less soluble anesthetic is like a faster acting drug.
Right. Now, I know you've probably wondered why we crank up the inspired concentration of anesthetic at the beginning of a case.
Oh, yeah. I've always been curious about that. Why do we do that?
It's all about manipulating something called the concentration effect. By starting with a higher concentration, we can speed up how fast the alveolar concentration rises. We're basically giving the anesthetic a boost to get it to the brain quicker.
So it's like jump-starting the process.
Exactly. And there's another cool thing called the second gas effect.
Second gas effect. I don't think I've heard of that one.
It's pretty cool. Take nitrous oxide, for example.
Yeah.
When we use a high concentration of it, it rushes into the bloodstream super fast,
Yeah.
and that creates kind of a vacuum in the alveoli.
A vacuum in the lungs. Interesting.
Yeah, and that vacuum sucks in other anesthetics that we're giving, like isoflurane or sevoflurane. It speeds up their uptake, too.
Wow, so the gases are actually helping each other out. That's teamwork.
It really is. Now, of course, getting our patients safely under anesthesia is only half the battle. We also need to think about how to get them back just as smoothly.
Recovery from anesthesia is like the flip side of the coin. We have to get those anesthetics out of the body efficiently.
You caught it. It's like airing out a room after a party, getting rid of those lingering fumes.
Perfect analogy. And just like with induction, blood solubility plays a big role in recovery, right?
Absolutely. The less soluble the anesthetic, the faster it leaves the body. And high fresh gas flows, those help to flush out the anesthetic too, like opening a window to air out the room faster.
Okay, that makes sense. But there's a catch with nitrous oxide, right? Something about diffusion hypoxia.
You're remembering correctly. Nitrous oxide leaves the bloodstream so quickly that it can actually dilute the oxygen in the alveoli, and that can lead to a drop in blood oxygen levels.
Oh, wow, that's not good. So we always have to be careful when we're using nitrous oxide.
Absolutely. That's why we give 100% oxygen for a few minutes after we turn off the nitrous oxide, to make sure the alveoli are topped up with oxygen.
That's a good reminder. So we've talked about how fast these inhaled anesthetics work, how they get in and out of the body. But the big question is, how do they actually switch off consciousness?
Ah, the million-dollar question. The truth is, we don't have all the answers yet. It's still a bit of a mystery. But we do know that inhaled anesthetics affect several areas of the brain, like the reticular activating system, which is responsible for keeping us awake and alert.
So the anesthetics are basically putting the reticular activating system to sleep.
You could say that. They also depress the cerebral cortex, which handles our higher brain functions, and they work on the spinal cord to block pain signals.
So it's like they're hitting multiple targets in the central nervous system, causing a widespread decrease in activity. And that leads to the classic effects we see with anesthesia: loss of consciousness, pain relief, and muscle relaxation.
Precisely. But we always have to remember that these drugs can have an impact on the developing brain, especially in young children. It's something we need to be mindful of.
Absolutely. Anesthesia is a powerful tool, but it's not without its risks.
Right. Now, shifting gears a bit, let's talk about MSC, minimum alveolar concentration. It's a really important concept for understanding how potent an inhaled anesthetic is.
I remember learning about MSC, but I always found it kind of abstract. How can we relate it back to what we do in the OR?
Think of MSE as the amount of anesthetic we need to stop 50% of patients from moving in response to a surgical incision. It's basically the ED50 for inhaled anesthetics.
Okay, so if an anesthetic has a lower MSC, that means it's more potent. Like we need less of it to achieve the desired effect.
You got it. So for example, halothane has a MASI of around 0.75%, and isoflurane has a MAS of about 1.15%.
So halothane is more potent than isoflurane because it has a lower MSC. We need less of it to achieve the same level of anesthesia.
Exactly. But remember, MAC isn't a fixed number. It can change depending on a bunch of factors, like a patient's age, their body temperature, their electrolyte balance, and even whether they're on other medications.
So we have to take all these factors into account when we're figuring out the right dose of anesthetic for each patient.
Absolutely. It's like solving a complex equation with multiple variables. Now, armed with this understanding of MAC and the other concepts we've discussed, let's dive into the specifics of each inhaled anesthetic, get to know their personalities, their quirks, and how to use them safely and effectively. Ready to meet the game?
Absolutely. Let's do it. Okay, let's start with nitrous oxide. Good old laughing gas.
Yeah, it's definitely known for its fun side, but nitrous oxide has some serious clinical uses too.
Like what?
Well, it's a pretty good analgesic, so we use it for pain management quite a bit.
Makes sense. But it also has those weird cardiovascular effects, right?
Yeah, nitrous is a bit of a paradox. On the one hand, it stimulates the sympathetic nervous system.
So that would usually increase heart rate and blood pressure, right?
Exactly. But then it can also directly depress the myocardium, which could decrease cardiac output.
So it's like a push and pull.
Exactly. Usually, the sympathetic stimulation wins out, so the heart rate and blood pressure stay stable or even go up a bit. But, we have to be extra cautious with patients who have underlying heart problems, that myocardial depression could be a problem.
Yeah, makes sense. And we also have to be careful with nitrous in patients with air-filled spaces, right?
Absolutely. Like a pneumothorax or a bowel obstruction, nitrous oxide diffuses so quickly it can actually make those spaces bigger.
Oh, right. That's a good point. So we really need to think about the patient's individual situation before using nitrous oxide.
Always. Understanding those unique properties of each drug, that's a big part of what we do.
Okay, so nitrous oxide, laughing gas with a serious side.
Yeah.
What about halothane? I know it's not used as much these days.
Yeah, halothane's fallen out of favor because of its potential to cause liver problems. There's this rare but serious thing called halothane hepatitis. It's basically a bad reaction that can damage the liver.
Oh, wow. That sounds pretty scary.
Yeah, it's not something we want to mess with, so even though halothane is effective, we tend to avoid it unless there's a really good reason. I mean, there are other agents out there that are much safer for routine use.
That makes sense. But it's still important for us to understand how halothane works, right?
Oh, absolutely. Knowledge is power, as they say. Like, for example, halothane can cause a pretty significant drop in blood pressure.
Really? Why is that?
It directly affects the heart muscle, makes it less efficient at pumping, and the more halothane we give, the worse the hypotension gets.
So we definitely have to be careful with it in patients who already have low blood pressure.
For sure. And here's another tricky thing about halothane. It makes the heart more sensitive to epinephrine.
So if we give epinephrine to a patient who's on halothane, that could cause arrhythmias.
Exactly. That's why it's so important to be aware of these interactions.
A good reminder. So halothane has some downsides. Are there any positives?
Well, it is a very potent bronchodilator, meaning it opens up the airways really well.
So it could be useful in some specific situations, like if a patient has bronchospasm during surgery.
Exactly. But again, always weigh the risks and benefits carefully.
Okay, halothane. Potent, but with some baggage. Let's move on to isoflurane.
Ah, isoflurane. This is one of the most popular agents we use for maintenance of anesthesia.
What makes it so popular?
Well, it's got a pretty good safety profile, doesn't cause as much myocardial depression as halothane, and it's very predictable in its effects.
So it's generally considered safer for the heart than halothane.
You could say that, but it can still cause some vasodilation and lower the blood pressure, so we still need to monitor those things closely.
Always monitoring. That's like our mantra.
It should be. Now, there's this theoretical thing called coronary steal that people worry about with isoflurane. Basically, the idea is that it could dilate coronary arteries in a way that diverts blood flow away from areas that are already narrowed.
That sounds pretty bad.
Yeah, but thankfully, studies have shown that it doesn't really happen in a clinically significant way.
That's good to know. What about other things to keep in mind with isoflurane?
Oh yeah, one really important thing. Isoflurane can trigger malignant hyperthermia.
Right, malignant hyperthermia. That's a big one.
Yeah. It's rare, but it's life-threatening, so we always screen patients for susceptibility before using isoflurane.
Absolutely. So isoflurane is a good workhorse anesthetic, but we always have to be vigilant about malignant hyperthermia. Now, what about desflurane? I remember learning that it's super fast acting.
It is. Desflurane is like the Usain Bolt of inhaled anesthetics, in and out of the body quickly. It's got really low blood and tissue solubility, so it's perfect for those short procedures where we want a rapid recovery.
I do remember it having a strong smell, though.
Yeah, the pungent odor is definitely a downside. It can irritate the airways and sometimes cause patients to cough or hold their breath, especially kids.
So probably not the best choice for inhaling induction in kids.
Right. And it's got a really high vapor pressure too, so we need to use a special vaporizer at high altitudes. Otherwise, it could literally boil off at room temperature.
Wow, that's interesting. Anything else we need to know about desflurane?
One more thing, desflurane can actually produce carbon monoxide when it interacts with those CO2 absorbents if they've dried out.
Oh, wow. So fresh CO2 absorbents are a must.
Absolutely. And we should always check them regularly just to be safe.
Desflurane. Speedy, but with a few quirks. Okay, last but not least, let's talk about sevoflurane.
Sevoflurane. This is a really nice one. It's got a sweet smell that's not pungent at all, so it's great for inhalation induction, especially in kids.
Ah, so it's the kid-friendly anesthetic.
Pretty much. And it's pretty good for the heart, too. Doesn't cause much myocardial depression, and it doesn't sensitize the heart to epinephrine, like halothane.
That's good to know. So
I know.
what are the downsides? There's always a catch, right?
Well, there's one thing to keep in mind. Sevoflurane can prolong the QT interval on the EKG.
So theoretically, that could increase the risk of arrhythmias.
Yeah, but it's very rare. But it's something we monitor for, especially in patients who already have QT prolongation.
Makes sense. Anything else?
There's also a potential for nephrotoxicity with sevoflurane. It can form this compound called compound A when it degrades in the CO2 absorbent, and that can be harmful to the kidneys.
So fresh CO2 absorbents are important here too, I'm guessing.
Absolutely. And using low flows can help to minimize the formation of compound A as well.
So sevoflurane, generally well tolerated, but with those couple of things to watch out for.
Exactly. It all comes back to understanding each drug's nuances and potential interactions. That's what makes anesthesia so challenging and so rewarding, right?
Totally. This deep dive into inhaled anesthetics has been amazing. I feel like I have a much better grasp of their individual personalities now.
Me too. It's like getting to know each member of the team, their strengths, their weaknesses, and how they all work together.
So to wrap things up for today, we went back to the basics of pharmacokinetics and pharmacodynamics, those core principles that guide everything we do as anesthesiologists.
We covered a lot of ground, from how drugs get absorbed and distributed throughout the body, to how they're metabolized and excreted, and then we dove deep into those fascinating inhaled anesthetics, exploring each one in detail.
It's amazing to think about how all these concepts come together in our daily practice. Every time we choose a drug, every time we calculate a dose, we're drawing on this foundational knowledge.
It's all connected. And as we continue to learn and grow, it's crucial that we keep building on this foundation, stay curious, keep asking questions, and never stop striving to provide the best care for our patients.
Couldn't have said it better myself. Thanks for joining us on this deep dive into Morgan and Mikhail. See you next time.